to our patients, because the patients who were considered not treatable or who were left to die on medical management because of high risk of the surgical procedure, or unfit or high surgical risk because of multiple comorbidities like kidney problems, lung problems, brain problems. Because we all know that these problems arises at old age, and with age we have multiple organs getting affected. So let's see what's coming up with the new. This is first is our topic is transcutaneous aortic valve replacement. We all know that the if we see the valve abnormality, most common valve abnormality all over the world is the aortic valve, which affects 2 to 7% of elderly population above 65 years. And if we see this normal aortic valve, the blood flow is quite smooth. But as the age advances, the load increases on the aortic valve, it narrows and leading to narrow flow of blood. So this is the how aortic valve stenosis happens, and when it happens, the left ventricle has to pump blood against increased blood pressure, leading to initially adaptation, hypertrophy, heart मोटा हो जाता है हमारा. उसके बाद with time it fails to compensate and it fails and heart function drops. So once it happens, once the patient diagnosed, he starts developing breathing problem, chest pains, giddiness, syncope. So it's the time for the operation. And standard treatment, which was used all over the world, was surgical aortic valve replacement, where we used to open the chest and we used to change this valve. And if we see that 30% patients with severe symptomatic AS were left untreated, either because of the inertia of our clinicians or because of the inertia from the patient that we don't want any open heart surgery. What will happen? What will be the recovery period? And many relatives of mine have died because of this open heart surgery. They don't want any open heart surgery. Or sometimes they're very high surgical risk because of kidney problem, lung problem, old stroke. So these patients were left on medical management and the outcome was very poor. So this technology, which was started in 2002, but gradually evolved over a period of time and adopted for the last 8 to 10 years, is considered very superior to medical therapy in those patients where surgery is not an option or surgery is very high risk. So these are the two pioneer trials with Medtronic and this is Edward Well, which clearly shows that if we do this percutaneous aortic valve replacement in high surgical risk or intermediate risk, yes, benefits are much more and the results are as good as open heart surgery. This is a small video which shows how this procedure is done and what we actually tell to the patient. This is through the catheter. We are going inside the aortic valve and from femoral arteries. Once we had went inside the aortic valve, we deflate the valve and the older valve is crushed to the wall and this new valve is deployed. It's just like a stent, coronary stent in the aortic valve. So this is the new aortic valve which is created and we come out from the leg and patient discharged in 2 to 3 days. So this was the conventional thing where we used to open the chest, patient used to stay in the hospital for 5 7 days, and then it used to take 1 month for the recovery period. But in this tower percutaneous procedure, patient is mobilized on 1 day and discharged on second or third, depending upon the recovery. So in surgery, we have recovery period of 7 to 10 days, but in TAVI, in appropriate patients, it's 1 to 2 days. So Patients are happy, the procedure is safe, effective, and it's now widely used in elderly population above 65 years. And early discharge routine reality and median stay in the hospital is 3 days. So the latest recommendation according to American and European guidelines is that if a patient is symptomatic with severe aortic stenosis, if it is low surgical risk, means age less than 65, no comorbidities, and lifespan is more than 20 years, then we go for surgical aortic valve replacement. But if age is more than 65 or 70, 75, he is an intermediate high surgical risk, then either TAVR or SAVR is an option. This is decided by a team approach we call hard team approach. And if patient has surgical risk, then TAVR is definitely better. And definitely is much more better than medical therapy. And we have a new option for our patients to prolong their life, to improve the quality of life. So this is our patient, Mr. BP 68-year male who came to us with breathing difficulty, NYHA class 3, and had chest heaviness. ECG shows narrow QRS complex, and echo shows EF for 20% with severe aortic stenosis. And he is a known patient of chronic kidney disease and maintenance hemodialysis. So these with poor heart function, kidney problem, age 68, he is a very high risk for surgical aortic valve replacement. And surgeons sometimes they consider that better to stabilize him first and then we plan something. But now with the advent of this TAVR, this patient was taken up after counseling for So this is our picture is an aortic root where we take a shoot of aortic valve and then this is a temporary pacemaker lead inside the right ventricle. This is the pictal catheter, and this is our TAVR catheter, which is going through after all the. So this black tube is the TAVR valve. This is the TPI lead, which we use for temporary pacing, and this is pictal catheter taking for the shoot. And after checking the position, we take aortic root angiogram, check the position of the valve, and we go inside with this. This is now we're going inside the left ventricle after checking the position, and then after checking everything, we deploy this valve. So this ring-like structure is the aortic valve, which is a new percutaneous valve. After checking everything, we come out and so this is our new aortic valve, which is being implanted percutaneous. And it is done from femoral root, and we close the femoral artery with the help of sutures, percutaneous sutures, so that there is no risk of bleeding and no risk patient can be mobilized in 8 to 10 hours. And then depending upon the recovery, we discharge the patient in a day or two. So this TAVR has definitely revolutionized the management of these patients. And when we have followed these patients after 6 months, 1 year, their heart function has improved from 20-25% to 40-45%, which is almost normal. And if you follow them more, we have seen even recovery to 60%. So they can live a normal life with normal heart function up to, you can say, 10 to 12 years with the help of this. Now coming to our next structural intervention is left atrial appendage closure. And what is this? So we all know that atrial fibrillation, we all must have encountered in our practice, this arrhythmia, which is known as atrial fibrillation, in which the heart rate of the patient becomes irregular and fast. And it is seen that it affects 1 to 2% of the population, and around 6 million European people suffer from this arrhythmia. And its prevalence is going to increase because as the patient age, as the population age, because of better lifespan, the incidence of AF also increases. So if we see this graph, which shows that in age 55 to 60 years, the incidence is less than 1%, but it increases as the age increases, and it's up to 15 to 18% above 85 years of age. So, what is the problem with this atrial fibrillation? That it's the most common cause of stroke. And we all know that stroke leads to debility, it leads to paralysis, it leads to decreased quality of life. And it is seen that in AF, stroke is the leading cause of death and third leading cause of disability. Why it happens? Because in atrial fibrillation, when heart fibrillates, it does not contract very fast. There is clot formation in left atrial appendage. This is the clot which we can see in left atrial appendage because heart is not able to contract very well. And this clot, when in left atrial appendage, it can migrate to the brain, to the kidneys, to the legs, and it can cause stroke, kidney failure, or peripheral embolism, or acute limb ischemia. So we need to take care of this clot either by anticoagulation, or if patient is not able to tolerate anticoagulation or he develops recurrent stroke despite an anticoagulation, then we have to consider for some other therapy. So how to anticoagulate? We all must be using in our practice this CHAD-VAS score. This is the score which simply says when to use anticoagulation. So it has definitive scores, and if it is one or more than one, then we have to anticoagulate these patients depending upon their risk profile, depending upon various anticoagulants are available. And this is the Hess blood score, which shows the tendency of bleeding of the patient. So if it is more than 3, then we have to take care that low dose of anticoagulant should be used and patient a very high risk. So we have to weigh thrombosis risk versus bleeding risk. But what happens to those patients who, despite anticoagulation or despite on anticoagulation, develop stroke or who cannot tolerate, like who develops GI bleed, who develops hematuria on anticoagulation, and they are at high risk of stroke? So, in these patients, there is a percutaneous closure of this left atrial appendage with the help of this device called as Watchman device. It's like an umbrella shaped device which is designed to reduce the risk of stroke by occluding this left atrial appendage. So again, it's a percutaneous procedure where we go into the left atria from the right side. We put all the cardiac procedures are done on wires and catheters. So this is the wire which is on the left atrial side, and we are going to occlude this left atrial appendage, which is the most common cause of clot formation. So this we select the device depending upon echo and TE images. And once we know the size and the selection of the patient, then we use this umbrella shaped device and we occlude this left atrial appendage, which is the most common cause of clot formation and which can go to the brain and can cause stroke. So two indications for this device are patients who develops bleeding on anticoagulation or who cannot, despite anticoagulation, they develops complications. So all these patients, or we know that patient who has to undergo surgery and has a high chances of bleed, then we can use this device. So coming to our patient, 76-year male, he is a known case of diabetes, hypertension, atrial fibrillation, and he was on anticoagulation, he develops GI bleed. And we know that if we stop anticoagulation, he is a high risk of developing stroke, kidney failure, limb ischemia. So his CHAD-VAS score was more than 3. So this patient was appropriate for this device therapy. Here, this is the TEE probe, which we put in the esophagus. And this is, we are using the broken bone needle to puncture the septum and go to the left side of the heart. And after checking the position, this is the device which is getting deployed in the left atrial appendage. This all is done under the guidance of transesophageal echocardiography. And after checking the position, this is the device which we have deployed in the left atrial appendage to prevent clot migration. You can see beautifully this device is seated in the left atrial appendage and taking care. And coming to the last modality in the structure is the CRT-D therapy. We all must be aware that patients who have heart failure, who have ECG, left bundle branch block, recurrent heart failure despite on medical management, then we have a device therapy available to promote synchronous contraction of left ventricle and right ventricle with the help of this device called cardiac resynchronization therapy device, defibrillation therapy. So this is a patient from Uttarakhand who 58-year-old dilated cardiomyopathy post ICD device, and last 3 months she had 3 hospitalizations in the hospital for heart failure, and for once she had to be intubated because of the recurrent heart failure. His heart function was just 25%. ECG showed left middle branch block, and coronaries were normal. Anti-pro-BNP were 10,340 and creatinine was 1.3. So despite on medical management, she was having recurrent heart failure and she had breathlessness on mild exertion, which prevents her from doing the activities of daily living, which is very, you can say, worrisome for a 58-year-old female and also for the family. So can we do something to improve her quality of life? So what happens in left bundle branch block? There is ventricular dyssynchrony. Right ventricle contracts earlier than left ventricle, leading to decrease in the function of the heart, leading to heart failure. So if we see this normal heart, so this is the normal heart which contracts. Both RV and LV they contract simultaneously. But if there is left bundle branch block, right ventricle contracts earlier than left ventricle, leading to decrease in the function of the heart. So what we do, we to maintain synchrony, we put 3 wires, one in the right atria, right ventricle, and left ventricle, and we stimulate both right ventricle, left ventricle together, so that the synchrony is maintained and our heart function improves. So this is done with the help of this CRT device, which we, like a pacemaker, we put it on the left clavicle. This is the device on the left clavicle, and these are the wires which are going into the heart, upper chamber, right lower chamber, and left lower chamber. And we contract these two together so that our heart function improves. So this was the ECG of this patient before the procedure. It showed broad QRS complex left bundle branch block. And this is the echo of the patient. We can see that LV is very poorly contracting. And after this, we put this patient on the CRT-D device. This is the device, and these are the wires inside the heart. And this is the post-procedure ECG. We can see a narrow QRS complex with subsidence of this left bundle branch block. And this leads to marked improvement in the function of the heart from 35% to 50% and leading to improvement in the failure. Patient was extubated and patient was discharged after 2 to 3 days. So other modalities which can be treated percutaneously are mitral valve therapy like mitral clip, mitral valve replacement, tricuspid valve therapies, and endovascular aortic aneurysm repair. And if there is leakage in the valve, one of the valve, we can close it by paravalvular device closure or post-MI device closure. So we have a plethora of percutaneous therapies which were initially subject to surgery, open heart surgery. Now we can do it by percutaneous depending upon the uh, profile of the patient. Though these percutaneous therapies are slightly expensive, but hopefully with more companies coming in and more research, we are able to bring down the price of these procedures. But at this time, they are very well tolerated and very well received, and patient benefit a lot. Thank you for this kind attention and a small